need to press the record button. Perfect. There we go. All right, that's most of the registrants. Awesome. Thank you guys for being on time. I can see you guys are eagerly waiting for this. So I'm going to jump right into it then. Hello, welcome on this beautiful Wednesday for our education session, kindly hosted by Leslie-Ann on Blood Cancer 101. Before we get started, I'm going to give you guys a little bit of housekeeping stuff. So my name is Gloria Lausch. I'm the virtual program coordinator here at Gilda's Club, and I'm going to be your tech support, background, chat throughout this whole thing. I've got two buttons that I need you guys to know about. First button, if you look at the bottom bar of your Zoom screen, it's called Q&A. It's got two cute little chat bubbles. So throughout the presentation, if you have any questions that you want to direct to Leslie-Ann, please put them into the Q&A. That's the only place she's going to see them. So if you want her to see any questions, answer any questions, make sure they go in the Q&A. I'll be reading them throughout. So if you guys have any questions that pop into your head as Leslie-Ann's going through the presentation, feel free to put them in at any time. And then I'll read them out to her when it's appropriate. There will also be time dedicated at the end. So if you're a little nervous or you don't think of anything until the end, that's totally okay. But again, once a question comes into your head for Leslie-Ann, put it into the Q&A. Then if you want to get in contact with myself at any point throughout this presentation, a little bit to the right, we've got a separate button that says chat. That's where I'll be. So any questions, comments, concerns, complaints, hopefully we've got none of those, then make sure you put it into the chat and I'll be monitoring both areas. So again, Q&A for Leslie-Ann and chat for me. With that being said, let's go into the actual fun stuff and talk about Leslie-Ann. So Leslie-Ann is a community services manager for Ontario at the Leukemia and Lymphoma Society of Canada. She's a compassionate connector for those who are part of a personal network or are living with a blood cancer. She studies at Durham College and believes in lifelong learning. She has a background in mental health and home care services and concentrates on servant leadership. She enjoys helping people find hope in the darkness after diagnosis. She specializes in psychosocial and emotional programs that include art therapy, peer support, and virtual support groups. That being said, all yours, Leslie-Ann.
Well, thank you very much, Gloria. I'm happy to be here and thanks for having me. So I have quite a bit of information to share today, and it is sometimes it's an overwhelming amount of information, but I will go through it as best I can. You can ask questions, as Gloria mentioned, throughout the presentation. And if there's anything afterwards that you'd like to talk about, you can let Gloria know and she'll get in touch with me. So here we go. So we've gone through welcome. So the objective of my presentation today is to just get you familiar with the definition of blood cancer and identify the types of blood cancer, remember some of the differences and the similarities, and sort of get familiar with the language around and involved with blood cancer, like blood cells, bone marrow, the lymph nodes, and other parts of your lymphatic system. So blood cancers involve your blood cells, your bone marrow, the lymph nodes, other parts of your lymphatic system. They can result from an acquired mutation to the DNA of a stem cell that are produced in your lymphatic or blood forming cells. The abnormal cells multiply much more rapidly than and are less likely to die naturally than our healthy cells are. So your lymphatic system is a network of tissues and organs that help get, rid your body of the toxins and the wastes and other unwanted materials that are in there. And the primary function is to transport lymph, which is a fluid containing infection-fighting white blood cells throughout your body. The bone marrow is a spongy tissue inside some of your bones, such as your hips and your thighs. It contains stem cells, which are often referred to as teenager cells. They haven't matured all the way yet. The stem cell can develop into a red blood cell, which carries oxygen through your body, a white blood cell, which helps you to fight infections, or platelets, which is what helps your blood to clot. There are 137 types of blood cancer, but there's 6 broad categories. Most of you will have heard of leukemia, or lymphoma, which is two different types, non-Hodgkin and Hodgkin. Then there is myeloma, and then there is myelodysplastic syndrome, which is known as MDS, or myeloproliferative neoplasms, which is also known as MPN. So we'll first talk about lymphoma. So lymphoma is the most diagnosed form of blood cancer. As you can see here, it's goes lymphoma to MPDs, then leukemia, then polycythemia vera, and then essential thrombolysis. I can never say that word. Thrombocythemia, myeloma, and then myelofibrosis. So there are two types of lymphoma, which I mentioned before. There is Hodgkin's and non-Hodgkin's. So Hodgkin's is one of the most curable forms of cancer, whereas non-Hodgkin's lymphoma represents a diverse group of diseases that are distinguished by a characteristic of cancer cells associated with each type. So we will talk a little bit more about the types of lymphoma, non-Hodgkin's lymphoma, in some later slides. So non-Hodgkin's lymphoma is a type of cancer that affects your lymphatic system. It generally develops in the lymph nodes, in the lymphatic tissue. In some cases, non-Hodgkin's lymphoma can involve your bone marrow or your blood. There are many different types of subtypes, which involve either an indolent or aggressive. So that's either slow growing or fast growing lymphomas. And the risk factors for most people who have lymphoma, there is no obvious reason or risk factor as to why it is developed. Sorry, I just need to move this so I can see. So how does non-Hodgkin's lymphoma develop? It usually starts with an abnormal change in your white blood cells in your lymph node or your lymph tissue, which is called the lymphocyte. It can start in one of three major types of lymphocytes: the B, the T, or the NKs. So B lymphocytes produce the antibodies to help you combat infections. The T lymphocytes have several functions. They include helping the B lymphocytes to make antibodies, and the NKs are also known as natural killers, and they are the ones who attack your virus-infected cells or tumor cells. So how does the abnormal lymphocyte will grow out of control and produce more abnormal cells like it? The abnormal lymphocytes will accumulate and form masses or tumors. And if the non-Hodgkin's lymphoma isn't treated, the cancerous cells will crowd out normal white cells, and the immune system will not be able to guard against infections. So non-Hodgkin's lymphoma will also develop in or spread to other areas of the body where lymphoid tissues is found. And most common is in the spleen or your digestive tract, as well as your bone marrow. So the signs and symptoms of non-Hodgkin's lymphoma, most common is painless swelling of one or more of your lymph nodes. Most of the time it's in your neck or your upper chest. Some of the other signs may include a fever without any obvious reason, drenching sweats, especially at night, and this is really drenching. It means you're waking up and your pillow and your sheet are wet. It's not just I've had the blankets on for too long and I'm a little hot. A loss of appetite, being tired and having no energy, or an unexpected weight loss. Some of the other things that you will start to see once the non-Hodgkin's is moving into a different part of your body are rashes, some bone pain, a cough, some chest pain, maybe abdominal pains, and some lumps under your skin. So non-Hodgkin's lymphoma is one of the cancers that is normally staged when it's diagnosed, and the doctors will determine the extent of the disease's progression, by using this stage. Not all people who are diagnosed with non-Hodgkin's lymphoma will begin at stage 1. And more than half of all patients that with intermediate or the aggressive type of disease, and more than 80% of patients with the indolent or slow growing are diagnosed right from the beginning at stage 3 or stage 4. If someone is diagnosed in stage 4, it does not mean that the disease is incurable. It really depends on the subtype and your personal biology, as well as the treatment type that your doctor will recommend. So we'll talk a little bit about the types of the non-Hodgkin's lymphoma subtypes are classified into categories that describe how rapidly they're growing. And I talked about this a little bit earlier. There's either an aggressive, which is also called fast growing or high grade, and that makes up about 60% of all non-Hodgkin's lymphoma cases. It is the most common aggressive subtype is diffused large B-cell lymphoma, or you'll sometimes hear that called DLBCL. And then there's an indolent, which is a slow growing or low grade, which makes up the other 40%. And the most common is follicular. Some patients with intermediate grade disease, which is something that will develop at a speed that's somewhere between the indolent and aggressive, and sometimes indolent non-Hodgkin's lymphoma can transform into an aggressive non-Hodgkin's. So the most common subtype. Yeah.
Just gonna pop in here. We got our first question.
Sure.
So you mentioned lumps under the skin being a symptom. Is this only where lymph nodes are, or can they be anywhere on the body?
It is most commonly where the lymph nodes are, but it can be in other places. It can pop up anywhere. So if you're having lumps that you haven't noticed before, they're getting bigger, but they're not hurting, it is a cause for you to potentially go and see the doctor. Does that answer okay?
That's perfect, thanks.
Okay. So the most common subtypes of non-Hodgkin's on the aggressive side, as we talked about, is the diffuse large B cell, again known as DLBCL. And then you have aplastic large cell lymphoma, Burkitt's, lymphoblastic, mantle cell, peripheral T cell, and then transformed follicular. And then on the indolent side, you have the regular follicular, cutaneous T cell, lymphoplasmacytic, marginal zone B cell, the MALT lymphoma, or small cell. They all have their own little abbreviations, and most of the time when doctors talk about them, they use the abbreviations. So one of the things, excuse me, that you need to make sure when your doctor is talking to you, if they are using too much jargon, you need to ask them to explain to you what it is that they're talking about. So now we'll move into the Hodgkin's lymphoma. Hodgkin's is also a cancer of the blood and bone marrow, and it's one of the most curable forms of cancer. It is the type of cancer that affects your lymphatic system, and it is named after Dr. Thomas Hodgkins, who was the first who noted a trend of cancer cases in the lymph nodes in 1832. For the people with lymphoma, there is also no obvious reason or risk factor as to why it develops. So it will start with an abnormal change to your white blood cells called your lymphocytes. Hodgkin's lymphoma is distinguished by the presence of the Reed-Sternberg cells, which are large cancerous cells. If untreated, the cancerous cell will crowd out your normal white cells, and the immune system will not be able to guard against infection. So lymphoma cells grow and form masses, usually in your lymph nodes located throughout the body in the lymphatic system. And lymphoma can also gather in the other areas of your body where there is lymphatic tissue. The signs and symptoms of Hodgkin's lymphoma are a lot the same of non-Hodgkin's. So you'll have the fever without an obvious cause. There will be a persistent cough, shortness of breath during normal activity. This doesn't mean that you've gone for a jog or you've been walking vigorously and you become short of breath, this is when you're doing a normal activity and your heartbeat is at a normal resting heartbeat. You'll have those drenching sweats as well. And normally it happens at nighttime. You'll be tired, no energy, and unexplained weight loss. The difference here is you're going to see some itchy skin and your spleen may become enlarged. So there are two types of Hodgkin's lymphoma, and one is called classic Hodgkin's, which is 95% of the diagnosis, which has 4 subtypes, and then there's the nodular. So that's Hodgkin's. Is there any questions at all about Hodgkin's at this time before we move into the leukemia?
Nope. Oh, we got one just as I said that. Are there dangers associated with an enlarged spleen?
Quite honestly, I can't answer that question. I could get back to you with the answer to that question. I should have sort of prefaced this at the beginning with I am not a healthcare provider or practitioner. I am somebody who works as a community services manager, but I would assume that there are issues with an enlarged spleen, but I can't answer that for sure. I'm sorry.
Okay, thank you.
So we'll move into leukemia. There are a few types of leukemia, and they fall into 2 categories. There's a chronic, and then there's an acute. So they are exactly what they sound like. One is the chronic are the type of cancers that once you're diagnosed, it is going to be with you for the rest of your life. And the acutes are you've been diagnosed and you're going to be moved into treatment really quickly. And it is something that we do look at as it can be cured. So this is how it plays out. So you would see that chronic lymphocytic leukemia, or otherwise known as CLL, is the most common. However, it has an age group, and I will talk about that a little later. Then your AMLs, or your acute myeloid leukemia, is your next diagnosed. There's a whole set of other leukemias in there, but the next largest diagnosis is your chronic myeloid leukemia. So so what you should know about leukemia. Leukemia is a type of cancer of the marrow and blood, the same as Hodgkin's. The results are acquired. It's not present from birth, and it changes in the DNA of there are changes in the DNA of a cell in your marrow that normally forms your blood cells, which are red, white, or platelets. The abnormal cells, the same as the other cancers we talked about, out of control, produces more abnormal cells that do not function normally, and then it crowds out your normal cells. Leukemic blasts will prevent the production of normal blood cells, and this will result in low red, white, or platelet counts. So the risk factors and the causes of leukemia are, again, they're not clear and there's no way to know, but there are a few factors that have been associated with an increased risk. So an exposure to a high dose of radiation, so if you lived through an atomic blast, previous chemotherapy or radiation, we find that a lot of people will develop a blood cancer after they have been treated for a different type of cancer. Agricultural pesticides, as well as genetic disorders such as first-degree relatives have also been diagnosed. And now my computer's not moving. So we'll talk about the signs and symptoms. So you'll notice that with the first 3 signs and symptoms, you're going to see it with all of the acutes and the chronics. So there's fatigue, shortness of breath, a loss of appetite. When you move into the pale skin, you're going to see that in both of your acute and only in your chronic myeloid. You'll see swollen spleen in both of your chronics, but only in your acute myeloid. You'll have a mild fever with both of the acutes, and then you'll have swollen lymph nodes with the the acute and chronic lymphocytic, and some frequent minor infections with both of the acutes and with the chronic lymphocytic. You'll see aches in your bones, bruising, and pin-sized red dots on your skin, as well as prolonged bleeding from minor cuts with your acute lymphocytic. You'll see swollen gums and potentially a swollen liver with your acute myeloid, and then night sweats and an inability to tolerate warm temperatures with your chronic myelolytic. So we'll talk about diagnosis and how your doctor will diagnose you. So for all 4 types, you're looking at an initial blood test, which will look at your blood levels, your blood count levels. So your red, white platelets, your hemoglobins, and they're looking for low, because what they're looking for is if your blood count is low, it means there's something else in there that's filling that space. So you're also going to probably, if your results are low or too low, or they're low for a prolonged period of time, maybe they'll send you for a test and it comes back low, and then they'll wait a couple months to see if it comes back low again, or if it comes back lower, and then they might send you for a bone marrow test. Then if that requires further information, they'll send you for an examination, a blood cell examination. They'll send your blood off to a lab to have it actually looked at to see if they can find the blasts that are in there. Now, with your chronic leukemias, a lot of times, and we will talk about this a little bit later, there is no treatment that happens when you are diagnosed. You'll be put on something that's called watch and wait. So what they'll do is they'll send you for what they refer to as a FISH test, and it will look at your specific DNA, and that will tell them if your blood results change and you need to move out of the watch and wait into an active treatment, which treatment you're actually going to be able to respond properly to. Now, with the chronic myelolytic leukemia, they may also send you for the chain test. It's really not that popular. Most of the time it stops at the FISH test, and but the majority of the people who do have that chronic side of the leukemia will live for a very, very long time on watch and wait. So we'll move into myeloma. Before we move into myeloma, is there any questions about leukemia moving forward?
Seeing you rolling in, there was one going question about lymphoma though, which I'm suddenly losing. Oh, here we go. Sorry, how do you know that you have an indolent or aggressive type of non-Hodgkin's?
That would be determined through testing with the doctors. So we didn't go through that with lymphoma, which is something that I actually should add to this presentation, is the testing stages. So once they have determined that you have lymphoma and then determine whether it's Hodgkin's or non-Hodgkin's, they'll do further testings to decide which subtype you have. And it's based on, looking at the blasts that are in there and looking at your blood levels and whatnot through a lot of blood tests, potentially also a marrow test. And they will decide what subtype you have. And depending on your subtype is whether it is indolent or aggressive. Does that answer that question?
That's perfect, thank you. And then we have one asking for a bit more explanation on the last 2 tests that were on the previous slide.
So the FISH test, again, is it's a DNA test, right? They're going to get your DNA through normal ways of doing that. They can either swab, they can do blood tests, and it simply is them looking at your personal markers and DNA, your personal biological makeup, and deciding with that information which active treatment your personal biology and your disease is going to respond to best. And it's not always done It is something that I have heard from the people that I speak to, that they actually have to advocate and push for themselves to have their doctor do it, because the majority of the time, as I mentioned with CLL, there is no active treatment. You are diagnosed, and then they continue to put you on what is called watch and wait. You would go back every 3 to 6 months, have your blood levels changed. If your blood levels stay even, they don't put you into active treatment. They will keep you on watch and wait. If your blood levels start to move up and down, they will send you back for blood tests on a more regular interval so that they can see how it's going. And if it starts to go in a direction that they feel that they need to start the treatment, then they will do that. And at that time, they would do this FISH test in order to decide which avenue of treatment would be best. The chain test is just another level of DNA testing, but it's only used for the CML. And it's just another level of, trying to pinpoint you personally, biologically, your disease, and what treatment is going to actually work best for you.
Awesome.
Is that good?
Yes, very clear. Thank you.
So myeloma is another form of blood cancer. And again, it is in your bone marrow, and it affects your plasma cells. More than 90% of the people with myeloma will have the subtype of multiple myeloma, and it affects several different areas of your body. The two groups that describe how rapidly or slowly the disease is progressing is asymptomatic or smoldering myeloma. It progresses very slowly. It's exactly what it sounds like. A fire smolders slowly. It doesn't burn really quickly. And then your symptomatic myeloma has related symptoms such as anemia, or can bring on kidney damage and bone diseases. And that is the myeloma that will be moving a lot more quickly. So how does myeloma develop? It is in your plasma cells, and again, it is a mutated cell. The plasma cells are made up of B cells, which is a type of your white blood cell, and it's present in your bone marrow. A healthy plasma cell is part of your immune system, and it is what makes the proteins that are called antibodies, which help you to fight your infections. A mutated plasma cell, it will, if it's untreated, they will continue to grow in the marrow, and they crowd out your healthy plasma cells and your normal stem cells in your bone marrow that form your white blood cells, red blood cells, and your platelets. And it can start to crowd out your white cells, and your immune system can't guard against infection. It will secrete high levels of protein into the blood and urine, which can lead to kidney damage. That it's the same along the lines as diabetes. You've got too much of something in your body, and your kidneys are fighting to get it out. So they're overworked, and it will be damaged. You can develop the fatty kidney disease. So it'll build up in your bones, and it will weaken, which can lead to painful bones and some fractures. So the signs and symptoms of myeloma are, the people who have myeloma generally don't have signs or symptoms, and they find out based on a regular medical checkup. You will go for a regular blood test for some reason, and when the results come back, it's there. Or you have let's say a urinary tract infection, so your doctor sends you for a urinalogy, and it comes back that there's too much protein, and they do further tests and a blood test, and it comes back that you have myeloma. So this is one of the ones that you will not know before you get the diagnosis. So the symptoms may include bone pain, they may include bone fractures, and there is no known cause or some infections. So The acronym to remember with myeloma that will describe symptoms are an elevation in your calcium, renal insufficiency. So there's deposits of myeloma or protein in the kidneys, and anemia, which is a low red blood cell count, bone abnormalities. And the treatment is usually recommended when one or more of those 4 symptoms are present. So the risk factors, again, there's no reason, no rhyme or reason for it, but there's a few things that have been noted that are, generally it's somebody who's over 50. More men than women will develop myeloma. There seems to be a more likelihood in African Canadians if there's a prior history or a diagnosis of MGUS or monoclonal gammopathy of unknown significance. If there's an environment where there was radiation exposure or certain chemicals, pesticides, fertilizers, and new research is bringing about the information that there's higher incidences of myeloma in those who are obese. So that's the myelomas. Is there any questions? I can see there's 2 in our question and answer.
Yes, we got a few. So what does non-secretory and secretory mean?
The secreting, where we go here, high levels of, I'm sorry, I'm not sure where that came from.
I believe, from what I was listening to, I believe it just refers to whether or not secretion occurs or does not occur, right?
Yes, that would be my guess, but I'm not sure where we saw. Oh, we saw that in the presentation. Sorry.
Next question, is SCT applicable to every patient?
Sorry, say that again.
Is SCT applicable to every patient?
Are you asking about a stem cell transplant?
Yes.
Well, no, it's not, because there's a lot of things that you can do prior to stem cell transplants. There's a lot of medications. There are a lot of, like with the chronic leukemias, you might be on watch and wait for a while. Then they would probably go to a chemo. They may try some oral meds depending. And then they might move to a stem cell transplant, but they don't always move to stem cell transplant. A lot of times the stem cells happen with the quick acute leukemias, sometimes with the excuse me, aggressive lymphomas, but they're not always the path that will go. There's also 2 types of them, and I will talk about that a little bit later in the treatment section. But there's an allo and a one where you're using your own stem cells, one where you're using a donor stem cell. So it really also depends on, again, your biology and the path that your diagnosis is taking.
Thank you. 2 more. What is the difference between stem cell treatment and CART in terms of side effects and prognosis for the patient?
So we'll talk about that a little bit later in the treatment section of the presentation, but the side effects of stem cell and CAR-T are, they're pretty much the same. CAR-T's really not that popular right now. It's still a new type of thing, and the recovery from both of them is the same. They're very major surgeries for people. Also, a lot of times prior to both surgeries, they are doing a really strong blast of chemo, which totally weakens the system. And so generally after both of those surgeries, you're going to be in hospital or have to live near the hospital for quite some time. So they are surgeries where your life is going to be you know, in an upheaval for a little while, as are the people that are in your life. A lot of hospitals have accommodations for that kind of thing. But sorry, does that answer the question?
Yes, makes sense. And then last question for this section. Please, do you have any more information you can share about bone abnormalities in crab?
Sorry, bone abnormalities in this?
Yes.
I guess it would be, they call them lesions. So it would be sort of, you know, you're getting little breakages and fractures that don't have any explanation. You may have major breakages and fractures from, you know, if somebody else fell down and they'd stand back up and they'd be fine, but your bones are breaking. There may be, you know, growths on them. There could be deformities in, because they're soft, they may, you know, be deforming in shape, that kind of thing. Is that what you're looking for, that information?
Yes, thank you so much.
Okay, so we'll move into the MPNs, which are myeloproliferative neoplasms. So again, this is a very rare type of blood cancer. And it begins again, the same as all blood cancers, with an abnormal mutation in your stem cells in your bone marrow. And it changes, excuse me, and leads to an overproduction of any combination of the white, red, or platelets. This is an adult condition. It does not happen, well, I'm not going to say it doesn't, but it normally doesn't happen in children. There are three types. There is myelofibrosis, which is known as MF, the polycythemia vera, which is known as PV, and then the essential, and this word always gives me a hard time, thrombocythemia, which is known as ET. The MF is usually developed slowly. Some people may live symptom-free for years. Others, however, may get progressively worse and require treatment in both cases. Patients do need to be monitored regularly. PV is a chronic disease, just like our chronic leukemias. It's not curable, but usually can be managed effectively for very, very long periods of time. And ET does not generally shorten a life expectancy. However, medical supervision is very important to prevent or treat any thrombosis that might happen. You'll find with anybody who is diagnosed with MPNs, subtype ET will have to have regular blood draws so that their blood does not accumulate or cause blood clots. And generally that can be just done at a normal place where you would give blood. However, they don't, they just dispose of the blood. Some others may have to have chemo, and they may need to move into the stem cell transplant. So that was very short and maybe not so sweet, but that's our MPNs. Is there any questions there?
Nope, no questions.
Okay, and now we'll move into the MDS, which is myelodysplastic syndrome. And this is a group of diseases of your bone marrow. Again, there are 6 types. They vary in degrees of severity, the same as the others. It is developing in your stem cells, and your bone marrow gets damaged, and it's called an acquired mutation. The stem cells from your blood cells are simply mutated, the same as the others, into a cancerous cell. It's just a different type of cancer than the leukemias and the lymphomas. The blood cell production in the marrow is increased more than normal. Blood cells are developing, and it is filling your marrow. So these blast cells die as they approach maturity, which would be before they would normally die. And so they're not being released into your blood flow, which would have you with a lower normal number of circulating blood cells. It may be primary or treatment related. So primary MDS has no obvious cause, but a treatment excuse me. A treatment-related MDS has an obvious cause. When they say treatment-related, most treatment-related MDS is developed after being treated for another cancer, so through the chemotherapy or radiation. It can happen at any age, but is most likely with elderly. And the treatment outcomes vary widely depending on your biology. So that is our MDSs. Are there any questions? Nothing at this time. So now we'll talk about treatment in general. So the fast facts about treatment planning is a person who has a blood cancer is usually treated by somebody who's called a hematologist or an oncologist. So don't be surprised if you are not referred to an oncologist, because this is a cancer of the blood and the blood systems of your body. Generally, a hematologist will be your specialist. It is essential to seek treatment in a center where the doctors are experienced with blood cancer. So generally your cancer centers. The treatment is always a risk versus benefit approach, which is why you'll find most of the chronic leukemias are not rushed through treatment, because sometimes the treatment is too harsh based on the fact that their levels are not at a worrisome level at this time. So with acute cancers, the treatment is started right after diagnosis. Generally, if you're diagnosed with an acute cancer, you are admitted to the hospital and a whole bunch of testing happens, and then a treatment plan will happen, and then we'll start your treatment right away. With the chronics, it can progress slowly or quickly depending on what type it is, depending on you, but the majority of the time a chronic cancer is put on watch and wait prior to starting an active treatment. So finding the best treatment for the diagnosis involves a lot of testing and a lot of fact finding. So the doctor will recommend your treatment based on several factors, which include the type that you have, the subtype, the phase that you're in or the stage that you're in, all of your blood work results, the identification of your chromosomes, what is related to the abnormality, your overall health, because they're not going to put you through a treatment that's going to deteriorate your health so that you cannot fight back once you've had that treatment. All of your symptoms, your white cell count, the cancer cell locations, the rate of progression, whether there has been cancer in the past and a subsequent chemotherapy was needed to treat it, whether there has been another blood cancer in the past, if the cancer is in the central nervous system, whether there's an infection, you know, if you're pregnant, and if the effective treatment will have any effect on the quality of your life. So treatment, this is our section number 1. So the watch and wait is, as I've mentioned, when you're closely monitored and monitoring the condition without giving any active treatment. So active treatment would be medication, whether oral or chemotherapy. It is until the symptoms start to appear or change. So chronic, you may be diagnosed but never have symptoms. So some people can manage their blood cancer on watch and wait for years using this approach. And it's usually in the early stages of chronic or slow growing cancers. Many people will tell you that it's very, very unsettling because they are now living knowing that they have cancer, but they're not doing anything about it in their eyes because they're not in active treatment. And they have this fear every time they go to the doctor of, what are my results going to say? So usually that's usually happening with your chronic cancers, and with most acute cancers, you're going to require some sort of active treatment as soon as you can after diagnosis. So we have chemotherapy, which is a cocktail of drugs or chemicals. is often combinations, it's often in intervals, and it's used to kill or damage your cancer cells. It has to be toxic enough to kill the cancer cells, which is why chemotherapy can be really hard on your body. The drug can also harm your healthy healthy cells, but cancer cells seem to be more sensitive to the chemicals in the drug than your normal cells are. The next thing that we have is radiation, and this is used. This is used for this. It's the same radiation, but in a higher dose than is used for your x-rays. It is also damaging the genetic material within the cell, which prevents it from growing and reproducing. So it's damaging your cancer cell so that it cannot spread or grow. It is directed at your cancer cells, but it can also damage your healthy cells that are nearby. The benefit is that it destroys cancer cells, and you have to remember that you have to outweigh the risk that it's going to also damage healthy cells, but it's usually part of a treatment plan that also includes the drug therapy. So here's where we talk about the stem cell transplantation. Some of you might know it as a bone marrow transplant. It's the two terms are interchangeable, and it is a procedure where they would replace your unhealthy blood forming cells with healthy cells. Stem cell transplantation allows the doctor to give large doses of chemotherapy or radiation to increase the chance of eliminating the blood cancer in the marrow and then restoring the normal blood cell process. So there's two types. There's an auto, which means that we're using your own stem cells, your own body to do that. They're removed, they're treated, and then they're put back in. Or an allo, which means that we are looking for a healthy person, a donor, somebody in your family or somebody that might be listed in the donor bank. So then we move more into immunotherapy. So immune cells or antibodies can recognize and kill cancers, and they're produced mainly in the laboratory and then given to the patient to treat cancer. It's usually given in a combination with chemotherapy. So you'll find that while on chemotherapy, we will also see that there's an antibody given, and the antibody is generally used to help the chemo kill the cancer, but also help to boost the immune system to be able to fight off anything that's coming your way while you're in the chemotherapy. It may also be used as maintenance therapy following chemotherapy. So once chemo is finished, you may continue with your antibody or immunotherapy. It generally results in fewer short-term side effects than chemo does. Another sort of treatment is a blood transfusion, and you'll find this with the blood cancers that create too much blood. So a lot of times you'll have the blood's drawn, and then you'll have sort of a replacement put in to sort of try to stop the blood from proliferating as much as and quickly as it will. Clinical trials are generally a controlled study that are conducted by doctors to improve treatments for people with cancer. There are a lot of them, and I won't talk about our services, but we do have a large clinical trials department in our US office that can help anybody who wants to try and see if there's anything they qualify for to find those studies. So that is pretty much the end of my presentation, and we have 10 minutes left. The LLSC, or Leukemia and Lymphoma Society of Canada, is here to offer guidance and support to anybody who is living with or is a personal support network of somebody with a blood cancer. And I did give Gloria a copy of our tear sheets that she can share with you guys later if there's any need to get in touch with us, but I stuck the slide in here of me and my beloved puppy so that you can know how to get in touch with me if you have any further questions afterwards, or if you're more comfortable, let Gloria know and she can get them to me. I hope that was informative, and I hope that it was helpful.
Awesome, that was fantastic. Thank you so much. I'm gonna give it a couple of seconds just as, oh, attendee, thank you about the pronoun check. Just gonna give it a few seconds for any last questions to roll in. So while we're waiting for that, I have some very, very exciting information to share with you guys. If you look into your chat right now, you'll see a survey. Now, we really appreciate you taking the time for us at Gilda's Club, but also for Leslie-Ann to fill out the survey. It gives us some feedback on what you like, what you don't like, what you want to see in the future. So we do share any results. They are not private, what's the word? Anonymous. We do share the anonymous results with Leslie-Ann and also with our fellow Gilda's team. I'm not seeing any questions rolling in. So with that, Leslie-Ann has kindly agreed to record and share the recording as well as the slides and an extra handout with you guys. So that'll be on the way later today. So be on the lookout for that. And that's all. Thank you so much, Leslie-Ann. That was great.
Thank you for having me and thank you for being here.
Awesome. Have a great week, guys.
You too. Bye.
Bye.